A preoperative evaluation is done before an individual can undergo surgery to assess their health. This is important because surgery and anesthesia are stressful events that can exacerbate underlying diseases. The goal of a preoperative evaluation is to identify diseases and risk factors that increase the risk of surgery and anesthesia, and to come up with strategies to reduce that risk. The American Society of Anesthesiologists created the ASA Physical Status Classification System for preoperative evaluations. This classifies individuals into 6 groups. 1 is a healthy person. 2 is someone with mild systemic disease. 3 is someone with severe systemic disease. 4 is someone with severe systemic disease that is a constant threat to life. 5 is a moribund person who is not expected to survive for long without the operation. And finally, 6 is a declared brain-dead person whose organs are being removed as a donor. If the surgery is an emergency, the physical status classification is followed by E for emergency. In addition to the ASA physical status, other operative risk factors include age, comorbid conditions in addition to systemic diseases, the operative procedure, the type of anesthesia, and finally, the surgical team and resources. That includes the surgical and anesthesia team, duration of surgery, and anesthesia, equipment, medications, blood, and post-operative care. The first key risk factor is age, and much of the risk associated with age is due to comorbidities like cognitive and functional impairment, malnutrition, and frailty. Next is exercise capacity, because those with good exercise tolerance generally have low risk. Next is complete medication history, specifically including over-the-counter, complementary, and alternative medications, which could cause an increased risk of bleeding. Most medications should be continued up to and including the morning of the operation, but some should be discontinued preoperatively. For example, monoamine oxidase inhibitors, or MAOIs, should be stopped 3 weeks before surgery because of the risk of drug interactions with anesthesia medications. The oral contraceptive pill should be discontinued about 6 weeks before elective surgery because of the increased risk of venous thrombosis. Aspirin should be discontinued 10 days before surgery. Thienopyridines, like clopidogrel, should be stopped 2 weeks before surgery, and oral anticoagulants should be stopped 5 days prior to invasive procedures. In contrast, selective cyclooxygenase 2, or COX-2 inhibitors, like NSAIDs, are okay to continue until surgery. In addition, individuals should be asked about alcohol, smoking, and illicit drug use. Alcohol and smoking increase the risk of surgical site infections and cardiopulmonary complications. Individuals with chronic opioid use may have tolerance and require higher than usual opioid doses in the intraoperative and postoperative period. Those who abuse opioids, barbiturates, or other amphetamines are at risk of drug withdrawal in the postoperative period, since they won't be getting access to these drugs. It's also important to identify a personal or family history of anesthesia complications, like malignant hyperthermia, which is a rare complication of anesthesia that can be due to an inherited condition that's autosomal dominant. At the time of the initial preoperative evaluation, it's specifically important to ask about cardiac symptoms and conditions. That includes angina, dyspnea, syncope, and palpitations, as well as a history of ischemic, valvular, or cardiomyopathic heart disease, and a history of hypertension, diabetes, chronic kidney disease, and cerebrovascular or peripheral artery disease. Individuals with a myocardial infarction in the previous 60 days, or with unstable angina, decompensated heart failure, significant arrhythmias, or valvular heart disease that affects their hemodynamics are at a very high risk for perioperative myocardial infarction, ventricular fibrillation or primary cardiac arrest, complete heart block or heart failure, or even death. The physical examination should focus on the cardiovascular system, including the blood pressure, auscultation of the heart and lungs, abdominal palpation, and examination of the extremities for edema and vascular integrity. For those with known heart disease that are undergoing a high-risk surgery, a resting 12-lead ECG should be done. ECG may also be done for asymptomatic individuals undergoing high-risk surgery, as well as for severely obese individuals with a BMI of 40 kilograms per square meter or higher, with at least one risk factor for coronary heart disease, such as diabetes, smoking, hypertension, or hyperlipidemia, or with poor exercise tolerance. The ECG tracing should be evaluated for the presence of pathologic Q waves, or significant ST segment elevation or depression, which raises the possibility of myocardial ischemia or infarction. The ECG might also show left ventricular hypertrophy, QTc prolongation, bundle branch block, or an arrhythmia. It's also important to ask specifically about pulmonary symptoms and conditions. That includes exercise intolerance, cough, and dyspnea, as well as risk factors like being a smoker and having COPD, asthma, obstructive sleep apnea, or pulmonary hypertension. A chest X-ray should be obtained in individuals over 50 years, undergoing high-risk surgery, including upper abdominal, aortic, esophageal, and thoracic surgery, or those with cardiac or pulmonary disease, or individuals that are severely obese. The chest X-ray may show signs of heart failure, cardiac chamber enlargement, or abnormal pulmonary vascularity suggestive of pulmonary hypertension, warranting more of a workup. Smokers should stop smoking at least 8 weeks before the operation. Preoperative pulmonary function testing with spirometry should be obtained in patients with unexplained dyspnea or exercise intolerance, and for those with COPD or asthma that are not at their baseline. A forced expiratory volume in 1 second, or FEV1 below 70% predicted, and a forced vital capacity, or FVC, below 70% of predicted value, and an FEV1-FVC ratio below 65% of predicted value is a risk factor for pulmonary complications after surgery. Finally, individuals must be screened for symptoms of obstructive sleep apnea with questionnaires, since it's often undiagnosed and increases the risk for postoperative medical complications like hypoxemia and respiratory failure. Preoperative laboratory testing is done when there's a specific clinical indication. First off, pregnancy testing should be done in all reproductive age women prior to surgery. Next, a CBC is often done to check the hematocrit levels in individuals over 65 years who are undergoing major surgery. It's also done in younger individuals undergoing surgery that could cause significant blood loss, as well as those with anemia. A platelet count is done for neuraxial anesthesia, so a spinal or epidural is planned. If a bleeding disorder is suspected, then a platelet count along with PT, PTT, and INR are usually checked. To test renal function, a serum creatinine is often checked in individuals over 50 years who are undergoing intermediate or high-risk surgery, if hypotension is likely, or when nephrotoxic medications will be used. A serum creatinine higher than 2.0 milligrams per deciliter, or 177 micromoles per liter, is predictive of having postoperative cardiac complications. Finally, an AST and ALT are usually checked in individuals with an underlying liver disease. Alright, as a quick recap, the ASA physical status classifies individuals into 6 groups. 1 is a healthy person, 2 is someone with mild systemic disease, 3 is someone with severe systemic disease, 4 is someone with severe systemic disease that is a constant threat to life, 5 is a moribund person who is not expected to survive without the operation, and finally 6 is a brain-dead organ donor. The history should be done to assess age-related limitations, exercise capacity, medications, and any personal or family history of anesthesia complications. Individuals with recent myocardial infarction, so within the previous 60 days, or unstable angina, decompensated heart failure, high-grade arrhythmias, or hemodynamically important valvular heart disease are at a very high risk for perioperative cardiac complications. These individuals should have a resting 12-lead ECG. Individuals at risk for pulmonary complications, including individuals older than 50 years, should get a chest X-ray. Smoking should be stopped 8 weeks before surgery. Individuals with COPD or asthma should get pulmonary function testing with spirometry. And everyone should be screened for obstructive sleep apnea with questionnaires. Finally, selective laboratory testing should be done for individuals with underlying risk factors.